Good afternoon, dear students. We continue our ophthalmological lectures. My name is Anna Kapayenko. I'm a professor of ophthalmological department. Today's topic is inflammatory diseases of the eye. We start from the inflammatory disease of the conjunctivitis. 80% of all patients who come to ophthalmologists have conjunctivitis. So it's rather often disease for young patients, for children, and for elderly patients also. Symptoms are very simple: redness of the eye, irritation, and discharge. As for objective signs, usually during examination of the patient, we can see conjunctival hyperemia or redness of the eye and different discharge. Discharge may be watery, mucoid, purulent, and the type of discharge can help us to suggest the type of conjunctivitis: viral, bacterial, allergic, or other cause of conjunctivitis. We should speak a little bit about classification of conjunctivitis. Infective conjunctivitis are bacterial, chlamydial, viral, fungal, protozoal, parasitic. A big group allergic conjunctivitis. I would like to say that nowadays more and more patients suffer from allergic conjunctivitis because of our ecological situation, because of our unhealthy food, and so on. Next group, irritative conjunctivitis. Keratoconjunctivitis associated with diseases of skin and mucous membranes, traumatic conjunctivitis, and keratoconjunctivitis of unknown etiology. I would like to show you some picture. Look, this is a typical picture for chlamydial conjunctivitis. You can see redness of the conjunctiva of the upper lid, edema of this conjunctiva. Here is gonococcal conjunctivitis, a lot of pus in eye. Here, bacterial conjunctivitis and viral conjunctivitis, mucus or mucowatering discharge. As for diagnostic of conjunctivitis, is not so difficult, and we should speak a little bit about the treatment of acute bacterial conjunctivitis, rather often disease as for the children as for the adult patient. Of course, at first we should prescribe antibiotics, topical antibiotics, wide spectrum. It may be ciprofloxacin, tobramycin, ofloxacin. We should prescribe these antibiotic drops rather often, 6, even 4 times per day. Before prescription of antibiotic drops, we should take samples from conjunctiva, and we should send the samples to laboratory, and this laboratory will give us the answer what is the cause of this bacterial conjunctivitis. But we receive this answer after 2-3 days. That's why we take samples and prescribe wide spectrum antibiotic. And we ask to the patient to come for the check-up after 3 days. We will see the clinical picture of this patient, and we will receive the result from laboratory. And if the patient feels better and we see the answer from laboratories that bacteria uh, is sensitivity has sensitivity to this antibiotic, we can continue this antibiotic. If not, we should change antibiotic drops. In the case of acute bacterial conjunctivitis, we don't recommend the patient bandage. We shouldn't prescribe steroids, and we can prescribe non-steroids anti-inflammatory drugs, but systemically. Usually it's orally tablets we can prescribe. Treatment of viral conjunctivitis, we shouldn't prescribe antibiotics. We can prescribe topical antiseptic like Vitabact, for example, for 8 times per day. And we can prescribe a topical antiviral gel, for example, ganciclovir Virgan, 4 times per day. Also, no bandage, no steroids, and we can prescribe in the case of great inflammatory process, irritation, we can prescribe non-steroid anti-inflammatory drugs systemically. Now we should discuss the inflammatory diseases of the cornea. This is part of the fibrosis layer. Normal cornea are vascular, sensitive, transparent, smooth, glassy, spherical. Inflammation of the cornea we call keratitis. If you see any opacity on the cornea, if you can see lesion on the cornea, infiltration of the cornea, we can think about keratitis. Objective sites of the keratitis: corneal edema, cellular infiltration, and ciliary congestion. When we say about conjunctival reaction, you should remember this chart. On this picture, you see unchanged portion of the eyeball. On this chart, on this picture, you can see conjunctival or superficial redness of the eye. On this chart, you can see pericorneal hyperemia of the eye or ciliary congestion. And on this part of the picture, you can see mixed injection of the eyeball. As for when we speak about redness in the case of conjunctivitis, it's a superficial redness. When we speak about keratitis, usually it's pericorneal or mixed hyperemia or injection. Okay, we have already mentioned the objective signs of keratitis, and now we should speak about complaints of the patient. A patient usually complains on photophobia. Photophobia, it's when the patient can't see on the light. Lacrimation or tearing, blepharospasm when the patient can't open their eye, sensation of the foreign body, and pain. You will see in your textbook and in a specific ophthalmological literature the words corneal syndrome. So corneal syndrome. It's a syndrome which is characterized all types of keratitis. And corneal syndrome includes patient complaints and objective signs. Classification of keratitis. All keratitis, we can divide it on exogenous keratitis, endogenous keratitis, and keratitis of unclear etiology. Exogenous keratitis, when bacterial agent or other agent uh, comes to eye from outside. And endogenous keratitis is a situation when pathological agent comes to eye from the patient body. So, as for exogenous keratitis, we can divide all these keratitis on corneal erosion, traumatic keratitis, microbial keratitis, keratitis caused by diseases of conjunctiva eyelids, fungal keratitis, corneal ulcer, endogenous keratitis may be infection like tuberculosis or viral, rheumatic, neuroparalytic keratitis because of avitaminosis. When we see the patient with keratitis, we can make a great investigation of such patient. We should try to find the cause of this keratitis. That's why we should make X-ray of nasal sinuses and the organ of the chest. We should send such patient for the check-up to the ENT doctor and dentist and make routine laboratory tests. Of course, we should try to find the cause I have already mentioned, infection agent, and we should make samples from conjunctival sac to try to find the cause. Is it viral or bacterial? Principles of keratitis treatment. Of course, if we know the etiology, etiological therapy. Or we should prescribe non-steroids anti-inflammatory medicines like inhibitors of proteases, prostaglandins, and uh, other biologically active substances. We should prescribe mydriatic solution like atropine or tropicamide. We should prescribe the drops which improve epithelialization of the cornea, like corneal gel, actovegin, sulcoceril, immunomodulators, antihistamine drugs. Also, we can prescribe the general therapy which improve nutrition, like vitamins. In severe cases, we can prescribe surgical therapy, surgical method. Usually, we use this method in a case of scars on the cornea after severe keratitis. We can prescribe the corneal transplantation, keratoplasty in a case of severe cornea cornea opacity. Some words about bacterial keratitis. Bacterial keratitis often develop in chronic inflammatory diseases of conjunctiva and lacrimal ducts, as well in a case of the trauma of the cornea. The risk factors for bacterial keratitis: contact lens wearing, non-surgical trauma, in some cases surgical trauma, corneal injury caused by lid dysfunction, corneal conjunctival or lacrimal dysfunction also may be the cause of bacterial keratitis. Treatment of bacterial keratitis. I have already mentioned that we have to take the samples from the cornea to determine the pathological agent. We should dilate the pupil by installation of tropicamide, and we should prescribe antibiotics drops, new wide spectrum antibiotics like tobramycin, levofloxacin, moxifloxacin, 8 times per day. In severe cases, we also prescribe antibiotic injection in subconjunctival. Look at this picture. I'm sorry. You can see these examples of severe keratitis. You can see even keratitis with necrosis. Here you can see the example of tuberculosis keratitis. For the tuberculosis keratitis, very typical clinical picture. You can see flictana and you can see neovascularization to this area. Rather often, we as ophthalmologists see the herpes simplex keratitis, maybe primary or secondary herpes simplex keratitis. Primary ocular infection typically occur in children between the age of 6 months and 5 years. This is rather severe situation, and this process is rather frequently accompanied by enteral uveitis, keratic precipitatis, early vascularization, hypoanesthesia, photophobia, blepharospasm, and lacrimation. Recurrent herpes simplex infection, we can divide on epithelial puncture keratitis, dendritic keratitis, metaherpetic keratitis, and disciform keratitis. On this picture, you can see the specific picture of dendritic keratitis. The picture on cornea is very typical, and we even don't need special laboratory diagnostic to say, oh, this is herpes viral keratitis. And clinical picture in these cases is help us to make a correct diagnosis and to prescribe treatment. Patients with a herpes viral keratitis usually usually complaints on photophobia, lacrimation, pericorneal hyperemia, and hypoesthesia. Look on this picture. This you see dendritic keratitis. This is like outcomes of dendritic keratitis. You see mm, opacities on the cornea, but here you can see severe, deep, distinform keratitis, herpes viral keratitis, very severe situation, very bad visual acuity, and this is rather mm, dangerous situation. Here you again on this picture you can see dendritic keratitis. Okay, as for the treatment of herpes simplex keratitis, we have a specific local treatment antiviral substances. It may be acyclovir or company name Zavirax, 3% ointment 5 times per day. Or we can prescribe ganciclovir Vilgan or 0.50% eye gel also 5 times per day. This is local treatment. It's a specific antiviral treatment. Also, we should add systemically antiviral uh, treatment. Usually, we use tablets. It may be valacyclovir or Valtrex tablets, 500 milligram 2 times per day, or acyclovir Zavirax 200 milligram 5 times per day. Also, we should prescribe metabolic therapy like Cornea gel or Tofol 3-4 times per day. Immunomodulated systemic therapy is indicated in a long severe um, cause of frequent recurrences. And deep form of keratitis rather often mm, may be the cause of eye hypertension. And in this case, we prescribe a hypertensive therapy. In severe recurrence cases, we can prescribe cryotherapy. It's like a surgical procedure. We go further. We have already discussed bacterial, viral keratitis, and now we should speak about keratomic causes. Risk factors of keratomic causes: long treatment with the antibiotic or corticosteroids. The next risk factors: micro traumas of the cornea, fungal skin diseases. Signs of keratomycosis: grayish white infiltrate with yellowish border. Hypopyon is also typical, and vascularization. Treatment of keratomycosis. Locally, it's a ketoconazole, miconazole ointment 4 times per day. Also, we can wash conjunctival sac with solution of boric acid. Systemically, we can prescribe Nizoral 200 milligram 2 times a day, or other anti-mycosis substance. We can add anti-allergic and anti-inflammatory eye drop. In severe cases, we can add paraocular dexamethasone, corticosteroids, uh, just uh, just 0.3 millimeters, because corticosteroids we couldn't prescribe very often, because corticosteroids can improve the growth of mm, fungal agents. Severe keratitis, deep keratitis, we call the ulcer of the cornea. Ulcer of the cornea is the inflammation of the cornea membrane, accompanying with necrosis with formation of the tissue defect. Infection may be bacterial, herpes, viral, fungal. Non-infection are immune diseases, corneal cirrhosis, and in a severe absolute glaucoma, in the case of very high intraocular pressure, may be also cornea ulcer. Risk factors: conjunctivitis, ductal cystitis, corneal sclerosis, traumas of the cornea, foreign body of the cornea, which um, uh, didn't remove at time, injuries by chemical, thermal radiation, laser affection, long wearing of contact lenses, operation of the cornea, and bullous keratopathia. There are some stages of ulcerosis process in the cornea. Stage of infiltration, stage of infiltrate decay and ulcer formation, stage of facet regression of ulcer, growth of epithelium that covers the fundus of the margins of the cornea defect, stage of the scar formation, stage of outcome, maturation and thickness of the connective tissue scar. This is a good way of ulcerosis process, but in severe cases, cornea becomes thinner and thinner, and here you see the full defect of the cornea perforation. You can see the hole in the cornea. It's a very severe situation, uh, and in this case, we mm, we should make keratoplasty immediately to close this defect. Principles of the treatment in infectious corneal ulcer. Also, we can, in better cases, we should know the cause of the ulcer and prescribe specific antiviral, antibacterial, antifungal, or antiparasitic treatment. Also, we should add metabolic, anti-inflammatory, anti-allergic, and immunomodulated hypertensive drugs. If we know that the cause of the ulcer is bacterial infection, we should prescribe antibacterial therapy, like in a case of keratitis, but we should prescribe more strong antibiotics more often. We can prescribe some conjunctival or paraocular injections of antibiotic by spectrum nowadays antibiotics. Also, we should prescribe this antibiotic systemically, like doxycycline, cefazolin, moxifloxacin. We should add anti-allergic and anti-inflammatory drops like Nacluf, Opatanol, and in a stage of regression, or we should add metabolic therapy which improve epithelialization like cornea gel, taufone, Vitasic. So we have already finished with the inflammatory diseases of the cornea. Other, we have already discussed the most important cornea inflammatory diseases. You can also read more deeper in your textbooks, and we go further, and we should discuss the inflammatory diseases of the sclera. Sclera is here is a cornea, and here white structure is a sclera. Episcleritis is the inflammatory disorders of the superficial layers of the sclera. It's self-limiting and frequency recurrent disorder of which typically affects young adults. The episcleritis may be nodular or diffuse. Episcleritis rather often is associated with collagen diseases, herpes zoster, syphilis, erythema nodosum, and other systemic diseases. Usually, episcleritis presents in young adult, and patient usually complains on severe pain, which is localized in the eye. The inflammatory process does not involve underlying sclera and intraorbital tissue. Episcleritis usually resolves spontaneously after 3 weeks, but may recur. Now, on this picture, you can see nodular episcleritis and diffuse episcleritis. No discharge, redness localized in a specific area, cornea is clear. In such cases, you can think about episcleritis. Episcleritis treatment, usually we use steroids, locally steroids, for example, solution of dexamethasone, 0.1% 5 times per day. Also, you can add orally or intramuscular non-steroids anti-inflammatory medicines. Usually, it's necessary to add non-steroids anti-inflammatory medicines for reduce pain and inflammation. Scleritis, it's a deeper inflammation that episcleritis. Scleritis is granulomatosis, inflammation of the sclera. Usually scleritis associated with systemic diseases like rheumatoid arthritis, ankylosing spondylitis, Ray's diseases, Wegener's granulomatosis, or infection like herpes zoster, syphilis, tuberculosis. So if you see the patient with episcleritis or scleritis, you should make the systemic checkup of this patient to send this patient um, for special investigation. Scleritis may be anterior, posterior, not necrotizing or necrotizing, diffuse or nodular. On this picture, you can see the examples of scleritis. Patient usually complains on severe boring ocular pain that radiates to the temple, jaw, or sinuses. Very severe condition of the patient. As for the treatment of scleritis, we should prescribe locally steroids, of course, systemically non-steroid anti-inflammatory medicine, but also in severe case we should use systemically steroids and try to treat the cause, systemic disease, which is the cause of scleritis. Okay, already finished with diseases of the external fibrosis layer, cornea and sclera. Now we should discuss the inflammation of the second layer of the eye or vascular layer. The inflammation of the vascular layer of the eye we call uveitis. Rather often disease, rather severe disease, and it's necessary to know how to diagnose and how to manage such situation. According to anatomy, we can divide uveitis on anterior uveitis. In this case, inflammatory process is affect iris and ciliary body. Intermediate uveitis affect ciliary body and pars planum. Posterior uveitis affect choroid and retina. You can say, oh, retina is not a middle layer, it's a third layer, it's internal layer. But choroid and retina have very good connection. And to tell the truth, we never have just retinitis or choroiditis. Usually we see choroidoretinitis. And panuveitis, inflammation of all part of the uvea, choroid, ciliary body, and iris. Clinical classification of the uveitis: acute uveitis, which lasts less than 3 weeks, and chronic, which last more than 6 weeks. Etiological classification of uveitis: we can divide all uveitis on exogenous and endogenous. So, exogenous, when pathological agent comes from outside, usually it's a traumas, traumas or surgical trauma, so after operation. And endogenous uveitis is caused by microorganism or other agent from the patient's body. Now we will speak about endogenous uveitis, because exogenous uveitis we will discuss during the traumas. Um, so endogenous uveitis may be associated with systemic diseases, infection, idiopathic. Pathological classification: uveitis may be granulomatosis or non-granulomatosis. Now we should speak about anterior uveitis. As for anterior, The patient usually complains on pain, photophobia, lacrimation, blepharospasm, blurred of vision, and redness. Signs, objective signs. We can see ciliary injection or pericorneal hyperemia, or in some cases mixed hyperemia. We can see meiosis of the pupil or irregularity of the pupil. We can see band keratopathy, corneal injection, or corneal edema, sorry, and keratic precipitates. Look at this picture, you can see keratic precipitates on the endothelium of the cornea. In anterior chamber, we can see flare. In severe cases, hypopyon. On this picture, you can see synechia. It's a connection between iris and anterior capsule of the lens. Or we can see loss of normal pattern of the iris, changes in iris color, and iris nodules. In the case of posterior uveitis, you have absolutely other complaints. If the patient, you remember, if the patient with anterior uveitis complains on pain, redness, discomfort, and so on. As for the posterior uveitis, no redness, no pain. It's appear because of choroid doesn't have sensitive innervation, so no pain. No. And the patient usually complains on defective vision, photopsia, black spot in front of the eye. During examination, we can see positive scotoma. And the most important, we, during examination using the ophthalmoscopy or slit lamp ophthalmoscopy, we can see the lesion of the fundus of the eye. And the complaints of the patient depends on this lesion. Where is this lesion situated? If in the center of the retina, the patient has a lot of complaints on bad vision. If it's in periphery, the patient in some cases doesn't have any complaints. The treatment of uveitis. Usually the aims of the treating uveitis are to prevent vision-threatening complication, to relieve the patient discomfort, if possible, to treat the cause of the uveitis. The four groups of medicine usually used in the uveitis treatment: mydriatics, steroids, cytotoxic drug, and immunosuppressive drug. And if we know the cause, we should treat we should use the antimicrobial or antiviral agent. Now, I would like to tell you about severe diseases of the orbit. I told you that our lecture will be inflammatory diseases of the eye, but I would like to tell you also some word about cellulitis, inflammation of the orbit. It's a severe condition, and this condition is dangerous not for eye, not for visual acuity, but also for the patient life. The risk factors of orbital cellulitis. At first, it's a sinus diseases, mm, infection of the other structures on the face, facial infection, ductal cystitis, dental abscess, trauma, and in the case of surgical trauma, orbital, lacrimal, and vitreoretinal surgery may be the cause of the mm, orbital cellulitis. In the picture, you can examples: exophthalmos, lid, eyelids, hyperemia, edema, severe edema. As for the symptoms and signs of orbital cellulitis, patient complains of headache, fever, pain, nausea. During examination, we see that eyelids are swollen, um, dermatosis, red, or warm and tender to palpation. We can see chemosis of conjunctiva. Ocular movements are restricted and painful. In advanced cases, visual acuity may be very low. I have already mentioned that orbital cellulitis is dangerous for the patient, and we can see the intracranial complication like meningitis, brain abscess, and cavernosus sinus thrombosis. Periorbital abscess also we can see in the case of orbital cellulitis, and ocular complication, keratopathy, in rise in intraocular pressure, high intraocular pressure, occlusion of the central retina artery or vein, optical neuritis. The treatment of the orbital cellulitis should be aggressive. Of course, it's hospitalization, intensive antibiotic therapy, retrobulbar injection, intravenous antibiotics, analgesic and anti-inflammatory drugs, osmotherapy. And when we see the patient with orbital cellulitis, it is necessary to surgical treatment. It's necessary to make surgical drainage. And of course, we should send such patient to ENT doctor, to dentist, to find the cause of this disease. And we should treat such patient together with the other specialist. If we make drainage of the orbit, but our colleagues ENT doctors don't make drainage from the sinuses, our treatment will be not effective. So be careful with such patient. If you see or if you suggest orbital cellulitis, you should react immediately. I would like to say you thank you for your attention. Hope to see you in practical classes, during our practical classes, and during our future lectures. See you and thank you for your attention.